friends and colleagues, Ramadan Kareem, and welcome to a new episode of EGVRS tour around the retina world in 30 days. Our stop today will be in South America and in particular in Buenos Aires, Argentina, to meet and welcome one of the renowned retina specialists all over the world and the professor of ophthalmology, Dr. David Pillais. Welcome, Dr. David.
Thank you. Thank you. It's a pleasure and an honor we part of these interviews.
Yes, the honor is mine. And can I say, ¿cómo estás?
Unfortunately, I don't know nothing in Egyptian, but it's really one of the best places in the world to me. I traveled 3 times. And it's really a fantastic place with unique in the world. I think so.
It's we will take after a minute about your travel stories. So first of all, we will take just a few minutes about your some personal information. We would like to know about Dr. David, your success story and the challenges you met in your career. So can I ask you, did you dream about the medical school while you are young, and how it ends up to be an ophthalmologist?
Well, I study as a student in the Buenos Aires University. The Buenos Aires University is a public university here in Argentina, and we have 3 Nobel Prize in medicine field around the past century. So it's a very important place. In the whole year, the university taken a very difficult examination, and only a small number of students can have the possibility to study in the university. So I start my studies in medicine around the end of 1980s, and at the beginning of 19, I made my residence in the San Martin Clinical Hospital. Is the hospital of the Buenos Aires University. Again, we have in Argentina another examination. It's a national examination with doctors of all private and public universities around the Argentina. And only we have 2 places in the Buenos Aires University Hospital as resident. I start my residence with Professor Sampaolesi, was a very famous specialist in glaucoma, you know. Then I finish my residence and start a fellow in retina with Professor Piantoni in Durán Hospital, is other famous professor in Argentina. And I really like the surgery. So I make a lot of vitrectomy at the end of the 90s. And also one of my mentors was Professor Borja Corcostegui in Barcelona. Borja really pushed me, and is really one of my mentor.
So you took your retina fellowship in Barcelona?
Yeah, well, I really was more of retina retina fellow, because Borja start with me not only about the surgery, about the retina field. Borja made my recommendation to be part of the Club Jules Gonan. I am member of the Club Gonan around 2017, and my mentor was Borja Corcostegui, and also Enrique Malbrán from Argentina is the other member of Gonen Club in Argentina. You know, the people in Argentina, in my years at least study more in Europe, you know, and less in America. You know, if, for example, if you've talked with a Brazilian, the people in Brazil may follow in States, and we, for our history, our connections with Europe, yes, we study in Europe, so it's different, you know. Also, other important always support me from Europe, Professor Bandello, Francesco Bandello from Milan is other important mentor to me, and Stefan Seregar in Sweden, also regarding tumors. And other guy was very important in my oncology evolution was Arun Singh from Cleveland Clinics.
Yeah.
We working in collaboration a lot around the years with a new program, a new instrumentation, and different papers. And in the last year also, I am part of the American Joint Cancer Commission. You know, this classification of the tumor TNM of all the tumor. We are more of around 300 of doctor of all medicine, and Paul Finger, and also Ram Simpson from Canada included me, but
very interesting.
Really support me also. So really, you know, in my evolution, I have a lot of support from international colleagues and friends, and really good friends. Not only friends as colleague in ophthalmology, friends in life. You know, when we are retired, still in connection for sure.
But very interesting and rich journey. Yeah.
Yes. I start with a surgical retina, and also intraocular tumors, because you know, I remember with Bertil D'Amato, I saw a surgery of Bertil D'Amato of endoresection and local resection in uveal melanomas, and really was a fantastic surgery. You know, take the tumor and don't take the eye with, well, was really
very difficult surgery indeed.
Yes, and this is one of the reasons because I start to make surgery, because it's, you know, at the beginning it's a complicated surgery, and very nice, so I enjoy, and well, and I start to this field, and I made around 8 books in English and in Spanish, more in English, about tumors, about diabetics, about retinal surgery, and well, I still enjoy the the work in the ophthalmology field, and I think so. In the next few years, we will see a revolution in the treatment of the surgical retina, and also in the intraocular tumors. Probably in the next years, change a lot of the diagnosis and surgical techniques and instrumentation.
Okay, thank you. Very rich journey, Dr. David, and we are very proud to have this interview with you. So let's go away a little bit from ophthalmology, and can I ask you, do you have any hobbies to practice in weekends?
Yes.
Do you like football?
Yeah, of course. But really my hobby, and I hope in the next year I have my first book in art. You know, wow. I am arts collector and Argentinian arts, and I really enjoy because it's like an escape, you know,
Definitely.
because if not all the time, all the day, I study and working in ophthalmology with
Your brain will burn out.
exactly, and really I enjoy the art, and I have other really interesting projects in art.
Which
So
art in particular you mean? Yeah,
well,
contemporary or
yes, I start with art. This type of art is a constructivist art. It starts in Uruguay with Torres Garcia. He's a guy from Barcelona, traveled to Montevideo and start this type of paintings. And some painting from Argentina, in special Adolfo Negro, start with these techniques. And then I changed to other expression in the art. We have a very famous painting live in Paris. The name is Julio Leparc, is from Argentina, and live in Paris from the 60s. And make kinetic art. It's like a geometric art, but with move,
Whoa.
you know. And other of my favorite art is Lucio Fontana. Lucio Fontana is the more famous artist from Italy, but really born in Argentina. And maybe you saw in modern art museum in the work the painting with cut. Well, this guy cut the painting. You say only the painting, you know, in green or white or wherever with cut. A lot of cards, or maybe one or three. And this guy is Lucio Fontana.
It's very interesting
Born in Argentina, yes, but working in Italy from the 50 or 60 to the death. And probably, I think so, is the more important artist of the 20th century in Italy. But start to work in Argentina. He's really an Argentinian artist, but you know, from around 20 something, live in Italy, and the fathers are from Italy. But again, the people from Argentina, a lot of people from Argentina coming from Europe in the early 19th, and also after the Second War. So, you know, we coming from Spanish, from Italy, from Germany, from Sweden. And this is also the reason, because we have this connection also with the artists, between this important artist from Europe, but really born in Argentina. Probably Lucio Fontana is the more important example.
So I assume that you travel for a lot of countries. What's your favorite country or favorite place you've been for?
Well, I really have two places. The first one is Egypt. You know, I always remember my first Nilo travel from Abu Simbel, and I can take all the Luxor Valley with the travel in the balloon, and also the fantastic Cairo Museum, fantastic. So really, I traveled 3 times to Egypt. Always, I have the invitation of the Vitreoretinal Society, but for sure, I really love Egypt. And the second place is Petra in Jordan. Really, also, I remember the first time many years ago.
Sculpture in the mountains.
Yes, I was invited by the Jordan Ophthalmological Society, and this was the first time I saw the Petra city. Is this city in stones behind the mountains, very old, and it's a fantastic place.
Yes,
Yes,
yes.
yes, yes.
So,
And in the third place is
uh,
Kyoto in Japan. Kyoto
oh,
is other amazing place.
another planet.
Yes, yes.
Yes,
I
Japan is another
remember
planet.
also another very good friends. I know around 2001 in the Pan American Congress in Argentina.
Mhm.
I was only a resident, you know, or finished my resident. I don't remember exactly, but was the first time I have a meeting with Yasuo Tano from Japan. Yasuo Tano is other guy really support me, and also it was part of the Gonen Club, and I remember the first time in Kyoto because one Club Gonan was in Kyoto. Unfortunately, Professor Tano dies, but was other great guy. And I forgot the other important person
Yeah.
support me, Professor Gisbert Ricard. Professor Ricard was the guy made retina. Is professor in Hamburg, and Professor Ricard was other still now very is retired, is one of my best friends in ophthalmology.
It's very nice to remember all the professors
Yes,
that all the mentors of you.
exactly.
That's yes, that's very
Yes,
good.
yes,
So, do you like cooking? Can you
yes.
cook?
Well, yes, I cook a lot. I cook a
You
lot.
cook a lot,
This is
really.
because I
So,
have.
what's your favorite? Your favorite
Well,
dish
you
food?
know, in Argentina, is always meat.
Uh-huh.
We have a type of cook. The name is asado, and we cook, you know, different type of meats, also fish. But here is more popular the meat. If you saw the Argentinian map, you
Uh-huh.
will see a lot of ocean and sea around the country, really big. But it is strange, in Argentina, all the people eat cow meat, especially cow meat. And the asado is very popular. Argentina was for many years the first country in import meat, cow meat, you know, and the beef here is very famous. Always we organizing a meeting here with the professor. Always the dinner is meat, you know, beef. Argentinian meat is the
It's
best.
interesting. It made me hungry.
Yes, yes.
So, so you
And
can.
always, and we have other two popular scene in Argentina. Remember, we coming from Italy, is the
Yeah.
pizza and the pasta.
Wow. Yes, I like
Pizza,
those.
pasta, every Sunday in the Argentinian homes, poor homes, rich homes, always you have on Sunday or pasta or cow meat, you know,
Yeah, yeah,
asado pasta.
yeah. Okay, thank you, Dr. David. Was the first part of the interview, and we'll have a break, and then we'll go for a second part, which will be your interesting scientific lecture,
Okay,
and see you there.
thank you. In the next minutes, we will see very controversial topics are the small pigment tumors, less of 3 millimeter of things. You know, in the general oncology, no oncology, ophthalmology, is very important the early diagnosis and start the treatment as soon as possible. To start this treatment, the general oncology is fundamental, transcendental, have the biopsy of the tissue and know exactly the tumor of the patient have. But in ophthalmology, the intraocular tumors, especially the more frequent, primary more frequent tumor, uveal melanoma, the treatment decision in general is about the clinical examination and the ecography. You know, also other complementary studies like the OCT and the autofluorescence, but the ecography is the most important. You know, we can see in this type of tumor, you know very well the different clinical presentation. The more important is the growth, the orange pigment, the location around the macula, the alteration in the acuity vision, and you know these all clinical prognosis factor, but all these prognosis factors are not pathognomonic of this small pigment or this small melanoma. So really are limitation the information we have. Maybe the more important is the growth. So we know in this type of tumor, very small, the ultrasounds in general don't work because the tumor are very thin and we don't have the correct information to make the diagnosis in this type of patient. So we think in this case, we need the biopsy or the fine needle aspiration biopsy to make the diagnosis in this type of tumor, and we can make the indication of the correct treatment. So regarding the fine needle aspiration biopsy, the more classic techniques is with 20G needle and made the suction with syringe. Depends of the location of the tumors. We can use a clear cornea by iris tumor. In the posterior choroidal tumors, we can use the transvitreal way with or without vitrectomy. In the tumors in the equatorial areas, we can use the transscleral way, and it's important in if we make the use transscleral way after the biopsy, we can use cryo or another technique because we have a less possibility of some cells starting the scleral layers. You know, for this small tumor, we describe in 2012, 10 years, in the BGO, with Arun Singh from Cleveland Clinic, we designed this needle. You know, as you can see here, the 20G, here our design, sorry, our designs is more smaller, the cut area, and with these marks every 1 millimeter. And this is because we know how of the needle is inside the tumors. For example, we need to know if the needle is 1 or 2 millimeters inside the tumor. With this needle is impossible, and also the cut area is too big to these very small tumors. In the second generation of this needle is the same design, but with the transparency at the end of the needle, and this is used with vitrectomy samples. In general, the sample is in the transparency area, and we have very good. We use the aspiration of the vitrectomy in the needle, and we have very good sample. With me, we made the first presentation in the Retina magazine with Professor Singh in 2017. But it is not only instrumentation problem, it's also how you make the management of this cell, because we have very small samples, and we use this technique of liquid base. Liquid base is a technique in general is used in gynecologic tumors, and the cells, the sample is not in It's in a special liquid, and this liquid made is an immediately fixation, preservation of the cellular morphology, and stabilization of the sample. Then, by cytoconcentration in 2 times, filtration, vortex separation, cell the sample, and the coloration. Because in these special glasses, with electricity around the circle, all these cells, it make like a biopsy. You know, it's like a sample of tissue and no only cells. And this is the concentration of 60,000 cells by millimeter in this cycle. We made this description for first time around 10 years ago in the European Journal of Ophthalmology with Professor Zarate. I think so it's good we see some sample. So we will see the complex of this situation. This is a girl only 14 years old with this tumor in the macular area. The tumor grow also with production of this area of subretinal fluid. The acuity visual is very bad. Also, the tumor is around the foveal area, as you can see here, and the size is 2.1 by 1.7 by 1.9 millimeters. So the ultrasound don't work in this type of lesion. You can see it's in the macular area, yes. Have a small orange pigment, yes. Have subretinal fluid and alteration of the retinal pigment epithelium, yes. But all this clinical presentation, it is not pathognomonic of this small girl have uveal melanoma. And if we put a plaque in the macular area, the patient will lose the central vision. And unfortunately to the patient, this eye is the eye with the better vision. So we need to know if the patient lost the central vision is because the patient have his own life, you know, and first is the life, second the eye, and finally the vision. This is the 3 steps in the ocular oncology. So we can see here the autofluorescence with the retinal pigment epithelium alteration and the subretinal fluids. The OCT confirmed the lesion. We know the lesion around the choroid layers and the subretinal fluids. And we use our needle to make the fine needle aspiration. You can see here the mark, 2 millimeters inside the tumor, no more, and take very, very small sample. Another very important is you need the very, very important ocular pathology, especially in cytology in the operation room, because maybe you need to make a second punction if you don't have good material, because nothing is work. You make this very complicated biopsy and you don't have material. So you need the pathology in the operations room, say, we have good material. I don't know if a melanoma or not, but I have the material, you know. When the pathology confirmed to me, as you can see in the cytology, is a uveal melanoma. Also, in this year, we use silicone oil because protect the optic disc to the radiation maculopathy. And you can see here endolaser around the punction area. As you can see here, the OCT with the macular area in good condition and the area of the punction. Unfortunately, the patient, we lost the central vision after the brachytherapy with iodine. Here is 8 weeks after the surgery. So as you can see here in this example, are very, very dramatic situation in this tumor. It's not too easy make this puncture, no, because it's a complex procedure. If you need to know very good the location, you need to have a very good sample, you know, with a small number of cells, and you need the ocular pathology in the operation room. And in some occasion, you need to make 2 or 3 punctions in this very, very small lesion. You can see here the efficacy and the diagnosis of with this technique. We have very, very good, with numbers more of 90% of the cases, in the less result in the transscleral, but around 95 and 97 in transvitreal lesions. And here the efficacy is similar. You will see here the tumor location in the intravitreal techniques, juxtapapillary, and more frequent in the macular area. And this is important because always we need to put the plaque around the macula or around the optic disc, so probably we have radiation retinopathy. Here in the transscleral is more peripheral in ciliary body or in equatorial area. So these cases we have less lesion by radiation. The more frequent complication, as you can see in this sample, sorry, I have time to change the slides, is a subretinal hemorrhage, as you can see here in this sample. So our point of view, of course, this is controversial. Not all the people around the world are agree, but in this type of lesion of high risk of clinical presentation, I think so we need to know what type of tumor is. And the only way is the biopsy, because the ultrasound don't work, and the clinical presentation, it is not enough. So in this situation, also, if we make a brachytherapy treatment, the patient lost the vision. So if the patient have a melanocytoma or nevi, lost the vision for nothing. So we need to be sure about the diagnosis. Also, now, in this day, some treatments like chemotherapy and immunochemotherapy need to know the DNA and the chromosomic, the genes and the chromosomes of the tumor, because the chemotherapy and the immunochemotherapy is personalized. So we need to know the genetic of the tumor. If we don't make the sample and put the plaque and destroy the tumor, also destroy the tissue and the gene and the chromosome. So if the people have a metastatic disease, and remember, the uveal melanoma make this metastatic seeding disease at the beginning of the tumor, when the tumor is very small, between 2 to 3 millimeters, more is more frequent the metastatic disease. So if we have a very big tumor, probably this patient already have metastatic disease or not, depends of the type of tumor and the genetic presentation. So the other point we need the sample is because each patient in 1, 2, or 3 years have metastatic disease, we have the sample to know about the chromosomic and the genetic information of the tumor. If not, the patient don't have good chance to survive. Not only the clinical diagnosis, you know, but in this type of lesion, remember always, the ultrasound don't work, you know. In the big tumor, you know the echogenicity and the characteristics of the ultrasound is the uveal melanoma. Okay, we know, but in these small tumors, the ultrasound don't work. It's only the clinical presentation. And in these cases, we need to take a sample. We prefer the fine needle aspiration biopsy. The other option is the biopsy with forceps, similar to the vitrectomy forceps. You can make the biopsy of the tumor. The way, well, depends of the tumor location, more peripheral, transscleral, posterior pole transvitreal. And this sample have two ways. First is the diagnosis. The cytological diagnosis is a melanoma, but the other part of the sample is from the immunohistochemistry. So we know the prognostic factor, the type of melanoma, because not all melanoma are the same. Not all the melanoma have the same activity, and not all the melanoma have the same frequency of the metastatic disease. So we need to know the RNA and the DNA with all different techniques, FISH, MLP, CGG, karyotype, and also now we have new stain with the immunohistochemistry, and we also know the type of the chromosome the tumor have. In conclusion, the fine needle aspiration biopsy or regular biopsy and a small pigment choroidal tumor of less of 3 millimeters, we need a sample of the tumor. You know, depends if you prefer the punction, if you prefer the biopsy, the way depends of the location of the tumor. You can use directly fine needle aspiration biopsy. You can use our needle, especially designed from the vitrectomy sample. It's your decision, but always we need a sample. I think so a new tool and new instrumentation we make more easy this process in the future. Also, the new diagnosis machine, probably we have more information about the biomarkers in this small lesion with the new OCT and angiography. And of course, we need more cases. It's not so frequent, this disease. No, the melanoma, this small pigment tumor or small melanomas, depends the result, is not so frequent disease. So always we need more experience in this type of cases. So I hope you enjoy the talk in this very well, it's one of the hot topics in the ocular oncology, really, because remember, in the past, in the books also, you can read, when you have this small choroidal tumor, you need to wait the tumor grow. Big mistake. Big mistake. If you wait the tumor grow and is a small melanoma, probably an aggressive small melanoma, probably this patient will die to metastatic disease in the hepatic area when you're waiting to grow. You know, you have this on mind. In the general ophthalmology, you will see the ophthalmologist say, "Oh, doctor, unfortunately, you have a brain tumor." But it's difficult, the biopsy from the location. So I don't know if good or not. We're waiting. If grow, is bad, and we make the treatment. You know, it is not logic, right? So all this is changed now, and we will change in the future. But I think so the general concept is, as in the general oncology, always we have the chance, we need the biopsy to have sure about the diagnosis of the patient, especially with the life of the patient is on the table around the future. Thank you for your attention.
Thank you, Dr. David, for this nice and comprehensive presentation. I have a question. You mentioned that one of the most common side effect is subretinal hemorrhage. A 25 gauge to take this biopsy, I think it's if you take it intravitreally, I mean, can any complications can happen. Um, the retinotomy will be larger. You need a lot of laser to close it. So any complication, any devastating
Well,
complication you
well,
faced?
yes. Well, when you make a lot of these procedures, you will see more complication. But it's really non-frequent. But remember, I also working in the surgery retinal field, so maybe I use gas at the end of the surgery. Maybe I use endolaser if I saw the borders of the lesion is not dry. For example, in this case you saw in my presentation, I make 3 punctions. This is the reason, because it's very big, the hole, and also I saw the borders or the hole, it's not dry, and this is the reason because I make this endolaser. So probably you have the idea, if you make a punction in the retina with the needle, you will have a retinal detachment. It is not this way, don't works in this way. But when you make a lot, or you need to make a punction two, three times by the same hole, well, probably you need to use gas or endolaser or another tamponage in the retina, and also the people have a lot of cases, so in very small number of cases, retinal detachment, and also vitreous hemorrhage is more frequent. But this number you saw is only in less of 20 cases, and was our fair presentation in this type of tumor, because I saw a lot of melanomas. But remember, we're talking about small melanoma, less of 3 millimeters. So when you try to find this type of a small pigment choroidal tumor, is not so frequent. So it's different, and it's totally different, the concept. In a big tumor, you also need the biopsy, because you need to know the risk of the patient to have in the future metastatic disease. And the only way, if you know the tissue and you know the chromosomic and the genetic presentation of the tumor. But it's very easy make a punction in a big tumor. It's not a problem. Also you can make the punction, it's a melanoma, because in these cases the ultrasound working very well. You made the punction and put the plaque. It is not a problem. But it's totally different of these complicated cases.
Very interesting, very interesting. Thank you, Dr. David. I really enjoyed talking to you today.
It was my pleasure. Really, I love Egypt, and it's one of the best places to meet. So.
We hope to see you.
Also, always the meeting of the Egyptian Vitreoretinal Society was a very good level. You have very good professor and speaker, and very high level in vitreoretinal professor. Well, a lot. I don't want to make a name, because always forgot something. But you have a very at the best level in the world, your retina specialist.
Okay, thank you very much, Dr. David. I enjoyed talking to you, and I can say buenas noches.
Perfect. Buenas noches.
Buenas noches.
Thank you again, and it's an honor to be part of this.
And we hope to see you soon in Egypt in the next HVRS meeting.
For sure. Always is a pleasure.
Thank you.